Okay, my name is Kim DeCoste, and I am one of the committee members who was introduced earlier by Curt, and I'm happy to be able to introduce our next set of speakers who will be giving us an introduction to state-based issues in politics. First on the speaker agenda for this session is Curt Anderson, who you have already met. He's a government relations professional with almost 2 decades of legislative and political experience. He is the Director of Federal and State Advocacy for AADE, and we're so happy to have him working with us on these initiatives. He oversees the association's advocacy program, including development and implementation of the association's public policy program, federal regulatory initiatives, and state licensure issues. Prior to his work at AADE, he was an assistant chief of staff for healthcare legislation in the Government Affairs Department of Illinois Governor Pat Quinn, who we enjoyed speaking earlier today. He participated in healthcare policy formulation, legislative action planning, and acted as point person on dozens of pieces of far-reaching legislation. He also created detailed legislative strategies for passage of each department's legislation and for killing numerous pieces of legislation deemed undesirable by the Quinn administration. In addition, he was point person for many of the coalition efforts put forth by the Quinn administration, and the coalition efforts included such issues as Medicaid expansion under the Affordable Care Act and restoration of certain Medicaid cuts and passages of various revenue enhancers, which you heard Governor Quinn speak of this morning. He also acted as the governor's House and Senate floor leader, where he personally represented the governor's interest on the House and Senate floors. And I will encourage you, if you want a fun story related to Curt, to ask him about an interaction he had with President Obama prior to his presidency. Okay, Bob Babich will be second, and he is our national legislative consultant. I've known Bob for a number of years, for a really long time, and my fun story related to Bob is the first time I met him was when he drove me along with 2 other nursing students and his wife, who was the president of our Student Nurse Association, to a student nurse convention. I don't know the type of the car it was, but it was long and it was loud, and we roared up the highway, but he got us there safely and back home. So, I would say Bob is a leading lobbyist in Kentucky, and actually even across the nation he does a lot of lobby work, so he's a lobbyist extraordinaire. His state capital successes include landmarks in healthcare, and one I will add is he was the person who helped us with the licensed diabetes educator legislation in Kentucky. So we appreciate Bob's work that he did with us and our work where we work together. So that was great. He was also very active with the Diabetes Action Plan. And if you want a sidebar conversation with me or Bob about that, we can help you learn about some of the successes that we think that has brought forward in Kentucky. So it's a powerful tool to get work done. So we appreciate his work on that. In addition, he was elected Secretary of State in Kentucky, and he has been in a lot of other roles. And so he's a personal friend of mine, and I will look forward to you all hearing what he has to say. Third on the agenda will be Marianne Hodorowitz. And I told her, I said, you know, when you're up in front of a group, Marianne, it's really hard to get your name out. But people mess up DeCoste all the time too, and I don't think it's nearly as difficult as her name. So she's a registered dietitian and certified diabetes educator and a certified endocrinology coder with an MBA in marketing. She's a consultant for health, food, and pharmaceutical industries and is recognized for her expertise in multiple diabetes topics. She especially loves helping clients achieve AADE accreditation for their DSME programs with her turnkey materials. Thus, she sees herself as a diabetes department store. Mary Ann has volunteered in many capacities within AADE. She served on the board of directors from 2013 to 2015. She's also been active on numerous committees of the Academy of Nutrition and Dietetics for over 20 years, including the task force that spearheaded the Medicare M&T benefits. I shared with her, I think our first experience working together was on the AADE reimbursement guide that was an online publication, and she definitely has figured out reimbursement far more than I have, because I'm still working on that in my current job in Kentucky, and I don't have an answer. We talk about the lack of answers every day, so we appreciate that we have her as an expert and that she will share with us. She has one husband, 2 sons, 1 cat, and she said in that order. In addition, champagne and chocolate are the other loves of her life. So with that, I'm going to turn it over to Curt to introduce us to state-based issues and policies.
Thank you very much. Thank you very much. We may be a little short on time, so we may have to skip over some things right now, but we'll go back to them tomorrow if we have to do that. We want to make sure everybody eats on time. So there are really 3 issues we wanted to talk about today relative to state-based issues, and these obviously aren't the only 3 issues out there, but this might be a good introduction and get you all thinking about other issues you may want to work on. So the 3 things we'd like to talk about are diabetes action plans, what those are about. We want to talk, Mary Ann's going to talk about Medicaid, and then we're going to talk about licensure, time permitting. Otherwise, we'll just roll that into tomorrow, but hopefully we'll get to that today. First, on diabetes action plans, how many people here are familiar with them? Okay, that's great. So we have a fair amount. So what are diabetes action plans? And if you look in your packet under tab 2, under state advocacy, the last 2 sheets of that section are about diabetes action plans. So diabetes action plans, or DAPs, they're either legislation, they can be executive orders that a governor signs, or they could, for example, as they did in Georgia, could just be a resolution that one chamber passes that's designed to encourage all the state agencies to work together and to collaborate to really come up with a long-term plan for addressing the issue of diabetes. And it's a way to ensure that state legislators and state policymakers are thinking strategically and taking steps towards reducing the prevalence of diabetes in their states. And this really is important for a number of reasons. And first and foremost, when you have a state body decide that this is an official position, you now have the incredible resources of a very large institution, the largest institution probably in a state, behind your effort. So, for example, not only do you have the expertise of a public health department or the department that deals with Medicaid, but you also have access to the experts that they have, and you're also able to set up an agenda whereby, and this is something we'll talk about in a little more detail, the state now, in some of these DAPs, actually has to decide what resources they want to dedicate, what monetary resources they want to dedicate to working on diabetes. And that's where the really tough arguments come in, and that's where the really tough work comes in, because as states are trimming their budgets, now we know what these diabetes action plans, exactly how much money states plan on spending on diabetes. And now you know whether you need more money, which I'm sure 9 times out of 10 we will, but it's a real roadmap for how states are going to start to deal with diabetes. So like I said, DAPs are usually the result of legislation or a resolution passed by both chambers of a state legislature. Although they can be an executive order from the governor, they're generally rewritten every 2 years. That's in the legislation. And another fundamental intent of the Dap legislation is to require state officials from various departments and from the agencies responsible for purchasing state employee health insurance to develop and report every year on a report that reflects the financial and health impact of diabetes. So, like I said earlier, these are very, very important because it throws the weight of the entire state government behind this one report. And really, it gives the state and it gives everybody who was involved in putting together the DAP a bully pulpit. That now you have a report that you can hold up and you can say to legislators and you can say to other stakeholders, this has now become a very high priority for our state, and it's something that we need to pay more attention to and to work on and to dedicate more resources to. A piece of paper and a report doesn't win the day, but what it does is it gives you the opportunity to use that report as an organizing tool to push for more of what we want in diabetes care in our states. So currently 18 states have passed DAPs and another 10 are considering passing their own. So here's the map of where we are. So the Tier 1 states that have passed DAPs, you can see Washington, Oregon, Wyoming. I won't go through the entire list. The next are states which are working on passing them right now. I have to say that this is a little outdated. For example, in Kansas and Indiana, where they tried to pass these just this session, those bills were killed. So those are two states where DAP legislation is not moving forward right now. And the primary reason that they did not move forward in Kansas and Indiana was you had the Department of Public Health saying that it was too expensive to try to put these plans together. And we'll address that argument a little bit later. And then the third tier is states which have neither a DAP nor introduced legislation for DAP. So there's plenty of states out there that still need to work on this issue. So I just wanted to give you some examples of DAPs and sort of walk you through them, because each state has a different one. So here's the Illinois DAP legislation. And one of the things that's so great about this legislation is that it basically always is in the same form. And it's very, very simple legislation. And let me make this a little bigger so you can read it. So I'm 52 years old and I'm technologically illiterate. So this is the best that we can do for right now. But there are copies of this, and you can get this off of our website. So really, this is, let me see if I can blow that up just a little bit more. Oh, sorry, just give me 1 second.
Is the Pennsylvania one that's in our books the same thing?
Yeah, they're very similar. Yeah, they're very, very similar. So just to walk you through, like I said, these are very, very simple. And what they say is these states need to come up with a report that defines the financial impact and reach of diabetes. And so these reports will spell out, this is what diabetes is costing us. This is what it's costing us in missed work hours. This is what it's costing in actual treatment. This is what it's costing in comorbidities. These reports do a very, very good job of spelling out and with very specific numbers what the cost is in diabetes in particular states. The real important issue, as far as I'm concerned, is number 5. And so, for example, in Illinois, and I know that one's hard to see and I apologize, but see if I can get this to work. There we go. So the development of a detailed budget blueprint identifying needs, costs, and resources required to implement the plan. That really is where the rubber hits the road. That now you're not talking in generalities. These plans are to come up with how you actually get money and fight for resources and fight for scarce state dollars in order to try to enact these plans. Like I said, if you have a plan, that's great, but you need the money and you need the organizing behind it to make sure that it happens. So just to walk you through very, very quickly some of the highlights in the Illinois Diabetes State Plan, and then I'll walk you through a couple of the other really good plans across the country. So every plan comes with a table of contents. It usually has a small introduction. In this case, it was from the director of the Department of Public Health in Illinois, and it's a very good overview and introduction of what's in the plan. And each plan, like I said, will actually spell out what the cost and the effect of the economic costs are in particular states. So for an example, in Illinois, in 2012, the medical expenses attributable to diabetes totaled $8.98 billion, and indirect expenses such as lost productivity, et cetera, more than $2.39 billion. And this is all fantastic information to have. Next, Illinois and a lot of the other plans and other states have done a very good job of spelling out the role of DSMT in the various state plans. For example, in Illinois, they do a very good job of pointing directly to provide single point of access resource guide on evidence-based interventions that include diabetes self-management education and links to providers throughout Illinois. So again, just having this in a plan in and of itself doesn't do a whole lot, but it starts setting the stage for taking action around these items. For example, in Illinois, they continue to talk about diabetes education. For example, strategy 3, to increase the number of evidence-based interventions offered to at-risk populations in diabetes high prevalence areas. So for example, the last one, expand reach of ADA and AADE accredited and or Stanford licensed diabetes self-education programs. So again, this is another reference made to diabetes education that was slipped into this plan, and it gives what you do a little bit of heft within the state government and with legislators. And for example, in number 4, again, you see the last bullet point, collaborate with ADA and AADE to research funding opportunities to fund future DSME locations within diabetes high prevalence areas. So you can see that there's a lot of attention being paid to DSME in the Illinois plan. Georgia passed a fantastic, they never passed a bill. What they did was the Georgia Senate passed a resolution on their own, and this can vary from state to state, but they passed a resolution which caused the Department of Public Health there to put together a diabetes action plan. Just 1 second here. So again, let me back up for 1 second. The really key point here, if I can get to it, excuse me, is, I think it's on the next. Excuse me. The second, whereas the Georgia Diabetes Action Plan will serve as Georgia's blueprint for improving diabetes prevention and treatment, community services, et cetera. So again, this is a very detailed blueprint for how to move forward, how Georgia decided to move forward with their diabetes action plan. And just to give you a few highlights, and again, there's a link to this. We have a page included in your packet that has links to all of these different plans. So for example, Georgia, again, and you'll see this in every plan, spells out the financial impact of diabetes. And I won't go into great detail here, but you can see Georgia spent a lot of time and effort going into their diabetes action plan and talking about what the costs are. And again, Georgia is another state that did a very good job of talking about DSMT in their programs, and just here's some of the key language. That diabetes self-management education is a proven way for people with diabetes to practice better techniques to manage their blood glucose levels and medications. And then they go into the 7 self-management behaviors. Now, this is the only plan I saw that went into this much detail about self-management behaviors. So they spell it out in their plan, which is fantastic. Another example within their plan is the next point below that, where they talk about during the education program, the participants are taught how to problem solve, make informed decisions, et cetera. These are all things that you know about, but this is now put forth in a state document talking about how to work with diabetes. So the Georgia DAP and the DSMT again. And this is very nice because, again, I didn't see this in any other diabetes action plans. Georgia really goes into a lot of detail about the return on investment for self-management programs. And I didn't see this in any other states, and they did a fantastic job of outlining exactly how much money, how this is actually going to save states a whole lot of money to do these diabetes self-management, to add DSMT into their DAPs. So they go into a lot of detail about that. Here's another example from the Georgia DAP. As you can see, I highlighted right there, establish ADA recognized, AADE accredited and or state accredited DSME programs in high need areas of the state. Again, the Georgia DAP and DSMT, they talk about support self-management supports at the community level. Points B and C, again, go into detail about the benefits of DSMT. The other state that's done a very good job of putting together a diabetes action plan is a state that didn't pass any legislation in order to do it and didn't have a Senate resolution or anything like that, and that is North Carolina. And this is a program that grew up organically. I'm sure those of you here from North Carolina know this story much better than I do, but this, the Diabetes Advisory Council in North Carolina started, I think, in the mid-'80s, around then, with a handful of counties, which is something the governor was talking about earlier. It started with a handful of counties, and it just grew organically, and they were able to become the center point, not the Department of Public Health, not anybody else. They became the center point for diabetes prevention in their state. And they've got a fantastic story to tell. So, you know, there's, like I said, there's more than one way to skin a cat. And I think all these states have shown different ways you can do it. You can do it with legislation. You can do it with a resolution. You can certainly go ahead and do it just on your own. So there's a lot of different ways that states and diabetes educators are approaching this way of making sure that these diabetes action plans really highlight DSMT. So how do DAPs help our grassroots efforts? If your state has a DAP, and we'll talk about this in a little more detail tomorrow when we talk about engaging with or this afternoon when we talk about engaging with your legislators, but it's a very good point of introduction to legislators and to policymakers. Hey, Representative, hey, Senator, you know, you guys already have a DAP. This is what I do for a living, and we're going to talk about the tools that we can give you. I know a lot about diabetes education. This is something you really need to talk about more in the DAP the next time it's written. When can we meet? When can we sit down and talk to you about what it is that I do and how we can help the state? If your state does not have a DAP, it's a great point of introduction to a legislator, again, to say, there's a problem of diabetes in this state. I've got the solution. Diabetes self-management training is a great way to help take care of this issue. You can talk about what other states are doing. As somebody mentioned earlier, it's nice to have a little competition among states. You know, there are states that are doing this. DAPs are working in their states, really elevating the issue. And again, we don't want to ask legislators to introduce that bill, but just talk to them and find out where they are on this issue, and then we can put together a very nice coalition in certain states where we might be able to get these DAPs passed. Does anybody have any comments on the DAPs in their states? I'm sure everybody here would like to hear what's going on in your states with DAPs.
I have to say, you have Pennsylvania listed there. Pennsylvania's had a DAP since the mid-'80s.
Mm-hmm.
I guess that's when Rendell was our governor, early 90s.
Mm-hmm.
And Linda Seminary sat on that committee that wrote it. And it's gathering dust someplace.
Mm-hmm.
It's ignored. The Department of Health has a diabetes prevention and control group or policy, and The funding for that is a real political hot potato. It comes and it goes, and it comes and it goes, and if anybody knows anything about Pennsylvania, we really have no budget, and I don't think we're gonna have any budget anytime soon, other than what can get done for schools, because we have a Democratic governor and a Republican House. So, it's to your point that, you know, one of the resources are, we now have a small group trying to revive it. There is the diabetes caucus passed a resolution where a report has to be generated each year. But the people that wrote the report didn't think diabetes was complicated enough to have a diabetes expert on it. I was at a meeting where they were showing off their thing, and you know me, I wasn't too quiet. So, you know, but it just is, I guess I'm just verbalizing my frustration of what's happening in the state, in that this is all really good. How do we have, it's got to have teeth in it.
Yeah.
And how do you get that? I think currently, right now, any diabetes funding for our Department of Health is sitting on the floor.
And like I said, it's great to have a plan, but it's very important that, you know, paper doesn't walk and it doesn't talk, but you do. And that's very important to have those plans out there, because it is at least a tool to organize around. And I think that'll vary from state to state how we do that. But it's a good first step, but like I said, it doesn't solve the problem by any means. Would you guys mind going up to the mic just so we can record everybody's question? Oh, okay. So let's take a couple questions and we'll move on.
Just as a follow-up, in 1992, I was fortunate to be part of a grassroots effort in South Carolina to raise awareness of diabetes, not only diabetes and the complications of diabetes, but the shortage of diabetes educators and education programs. In 1994, we actually achieved legislation support, and we've had financial support for our diabetes initiative of South Carolina for the past 24 years. This push has brought in more CDEs to our rural areas and also DSME programs in community-based in clinic areas. My question is, why is my state white?
Why what?
Why is my state, South Carolina, pictured as white? In the diagram as having no DAP, and I'm just floored that we've been here forever. And we've got our second 10-year strategic plan up and all the data has shown the reduction in the complications and the improvements that we've made, and we've moved at least from 5th place in 1992 down to about 4th. So
yeah. Oh, well, we'll have to correct that on the map.
4th to 6th.
And I think, too, maybe why South Carolina's white, even though you do lots of really good work and stuff, and I mean, because you all are a very proactive state, I know, but maybe it's because, is there not the actual state legislation that says a diabetes action plan? And what we know is when you have the legislation that assures that it will continue. And some experiences we've had in Kentucky that Bob and I can both attest to, as well as some other people here, is sometimes things go away. So if you have the legislation there, then that makes your state stay the color. Not that we always like it or like the extra work that it has to do, but I wanted to bring up when ours was passed, it was hard work, and of course it has to be led essentially by the Kentucky Department for Public Health and the Diabetes Control Program, but it opened the dialogue with those other agencies to actually make something happen when you wrote down, well, we support those things, just like Curt was reading DSME, and we support DPP, and now like our Kentucky Employee Health Plan, which is part of that, actually pays for DPP for all of those employees. That's our biggest insurer. I had a nice meeting a few weeks ago with the commissioner of that to actually ask if she would consider a pilot or doing something related to removing cost sharing for DSME for those employees as well. So that's the advantage of having something like this in place, because it gives you almost a legislated audience where they have to listen.
And Bob can talk to this a little bit more.
terrific to be with you on May 13th, which happens to be National Hug a Lobbyist Day. Something I was able to create earlier this morning. Lobbyists are lovable people, and I'll speak to that in greater detail if you'd like, personally, as we have a chance. The DAP, back, let me think of this exactly, it was December of 2010 when Tom Boyer of Novo Nordisk called me and said, fabulous human being, got an idea. And so we ended up putting that in law in Kentucky. We can talk all about the dynamics and how the decision moved around and so on. What it underscores for me is a belief I have that our job in advocacy, I will not call you lobbyists, but advocates because it sounds so much nicer. Our job is to keep a continuous conversation and to be a convener when we can through forums like this or centers of influence back home. I get the chance to talk a little bit more about that this afternoon. I've known Kim for a long, long time, and her family before her, because was it your uncle, I believe, Mr. Coy, was a center of influence in Little Richmond, Kentucky. And Mr. Coy had a gravitas that you could sense and that I was aware of as a kid. Mr. Coy is exactly the kind of person who could ask a legislator, a man or a woman who might not be or might be very interested in our subject, to put this subject before a committee or a group, or simply call the people in. We've had two very dynamic women in the health secretary's role, Secretary Glisson now and the secretary before as well. And they're conveners. They make people talk about stuff. I'm not sure that the DPP would be covered in the state employee health plan unless it had been driven by the DAP conversation. A very enlightened commissioner listening to Medicaid friends, some of whom he had never met, and public health also in that conversation. And you'd think we'd all be talking all the time anyway, but it doesn't always work out. But when you've got to put a report back to the legislature, and that's a requirement, then something's got to give. And what gave was that great human emotion that you start to like people, you start to know a little bit about people, and you start to connect. And those leaders connected and produced not only a good report, but other great results, conversations, and spinoffs from that. So I can understand that in a particular state you're stuck, the legislative difficulty, the funding difficulty. And one great senator, a great woman from Northern Kentucky said when we were talking about the DAP, isn't this a recipe to ask for more funding? Well, we're losing ground every year. I think we can make the case for more funding most any time. But fact is, you put the data together, you put the people together, you put the thinking together, and you end up with a different relationship, a different conversation that stays permanent, even as administrations change and as people change. And you begin to see a reaction. When we presented the DAP in November, 3 of us, very intelligent, conservative members of that joint committee on health said, it looks like we should be doing more of that. And that was the DPP. Leaders constantly say, I get that it's a problem. What do you want me to do about it? What should we be doing about it? And whether it's a plan like North Carolina or Georgia or however it comes down, if you want to do a DAP, call Novo again. They have spearheaded this forever. And I appreciate all the corporate sponsors here who help with things like this and things like that. But what happens is keeping that conversation and being a convener yourself, chairing that work group, creating it, driving it. You do anyway. You have a circle of friends who are professional, who are civically engaged, who are otherwise involved back home, and they rely on you for information and inspiration and a little urgency. So it is that urgent lobbying that Chuck and Curt and Hope and others are building here. Deb Outlaw and I will have a chance to talk with you more this afternoon, a little more specifically, but any question you have, we'd love to entertain when we get the chance.
Mary Ann Hodorowitz is next. She's going to talk about Medicaid and the reason that we thought it might be a good idea to talk about Medicaid is because if there's one thing that could really be the most susceptible, depending on how the elections turn out at the state level and depending on what's going on federally, it's what could happen to Medicaid. So we thought having a nice overview of where Medicaid and DSMT are right now, and then what the possibilities are, depending on, we don't have a crystal ball to see into the future, but we think we could make some pretty good guesses as to what could happen.
The slides.
Right here.
Okay, thank you. Well, I realize I'm standing between you and lunch, which is not always the most enviable position to be in. I apologize for my voice. I was consulting yesterday at a weight management clinic, and I was just talking all day. And for those of you who know me, I don't have an issue with talking. Okay, let's get going because I'm going to try to shorten this from 20 minutes to 15 minutes because we're running a little long. So first of all, what we all have to do as a group, as diabetes educators, is maintain knowledge of each healthcare insurer's rules for DSME if we're billing insurers. And every insurer makes their own rules, including Medicaid, if they pay, because they can. They can. They make up their own reimbursement rules because they can. So with endocoders, with my colleagues in the coding industry, we talk about the golden rule. He who has the gold makes the rules. And he who wants the gold has to identify those rules and follow the rules. And he who doesn't follow the rules has to give all the gold back plus penalties and fines. And then that person is out of a job. And so the reimbursement rules, particularly with federal and state insurers, can be complicated. It's all about the C's: complicated, convoluted, confusing, and constantly changing. That's what makes it difficult. The good news is that 47 states right now, plus the District of Columbia, have state-mandated coverage laws. The state of insurance in that state mandates that certain diabetes benefits, including DSME and MNT and syringes and self-monitoring equipment, gets covered. And the 4 states that do not have laws, you can look up all of your coverage in your laws, state-mandated, at that URL on the slide. But the 4 states that don't have state-mandated insurance laws for diabetes-type benefits are Alabama, Idaho, North Dakota, and Ohio, just to let you know. So what we did in the slide deck, again, I apologize for my voice, from that URL, that state legislature URL, we pulled California, and I circled in red. They seemed, California could be a country all by itself, right? It's so big. And so you can see in red that California does cover insulin using diabetes, gestational diabetes. Really good news here: medical nutrition therapy and diabetes outpatient self-management training. So California seems to really be advanced here. Now Illinois covers it also, but they will determine, Illinois covers diabetes education mandated, but every state will have their own hours with that state mandate, that state insurance mandate, and their own other reimbursement rules. So let's move to another topic, and that is with us as grassroots educators and grassroots advocates for what we want at the state and federal level. Curt and Chuck and Leslie asked me to put together talking points for when we do meet with decision makers, Medicaid decision makers, Medicare decision makers, Blue Cross Blue Shield, whoever we're working with who has, who's holding, they're the gatekeeper to our benefits. What is our talking points to convince them to cover DSMT and MNT? So these talking points are going to follow the acronym Medicare and DSMES, just to have some fun. So let's just go through some of the, so picture yourself in front of a Medicaid guru, a Medicaid vice president or a CFO, somebody really high up on the totem pole, and you're meeting him for the first time to convince him to cover DSMT. So we want to tell them that Medicare Part B covers outpatient DSMT. So what's the holdup here? I mean, if Medicare, this federal program, can do it, why are you not doing it? And that certification is required for coverage with Medicare. And the 2 bodies that grant that certification is AADE, and they call it accreditation, and of course ADA, and they call it recognition. The second talking point is that evidence shows that DSME is cost effective. Now, we all know this. I'm not teaching you this. I'm talking about a lineup of talking points when we're meeting with the decision makers at Medicaid, a managed care organization, Medicare, Blue Cross, Aetna, Cigna, whoever is holding that string to our benefits. The evidence shows that DSME is cost effective and that the average Medicare cost saving per member per month is $135 when the beneficiary has attended a program, and that's really good news. I'm following the acronym Medicaid, the D. Diabetes educators are preferred providers of DSME because of our specialized education and training, and we know that. And then we want to remind that decision maker about the CDE credential and the BCADM. And just to let you know that Ann Daly, Ann, raise your hand, Ann wrote a wonderful article about her experience becoming a BCADM and what it meant to her career. And that's on the Advanced Practice Community of Interest on the AADE website. It was really well done. It gives a personal experience with getting that credential. We want to tell that decision maker that AADE is the premier membership association representing us with over 14,000 members, and that our members are not just RNs and RDs. We represent a wide variety of healthcare disciplines. And you know what? You could actually copy these talking points and have them in your back pocket. You know, I remember when I was getting one of my advanced degrees, and I felt really guilty, but I didn't know one of the answers to some of the accounting questions, and I wrote the answers up my arm. Isn't that terrible? So, yeah. And so we're talking about a cheat sheet. This is like your cheat sheet when you go in and talk to these decision makers. And that ADA does develop strategic partnerships with stakeholders, we know that, to advance all diabetes type benefits and activities. Something you may not know, and this is new, that there was implementation in 2013 of a rule that affects the type of providers of preventative services that Medicaid now can directly reimburse. And this could be a yin-yang, a good or bad, depending on how you look at it. Right now, this new ruling allows Medicaid to bless non-traditional practitioners with reimbursement in the area of diabetes education. And we're talking CHWs or health educators, that's their term, CHWs and health educators. But if they do, they can do that now. They can say that this group of healthcare professionals can be reimbursed even though they're non-traditional. But they can make up, again, all their own reimbursement rules around those non-traditional healthcare people. Prior to this rule, prior to 2013, Medicaid programs were only allowed to reimburse for licensed healthcare professionals in the healing arts, the more traditional, like physicians, dietitians, that sort of thing. The other talking point here is that coverage of DSME by all Medicaid programs in all 50 states will increase access to and utilization of this preventive and chronic disease management protocol. Some people look at it as preventive. A lot of us look at it as what? Disease management. It could swing both ways. And so what we have to know our audience who we're talking to. If the audience we're talking to is into prevention and it's in the preventive arena at Medicaid, then I think we have to present it as a preventive service. Got to know your audience. You know, I remember when I was getting my MBA in marketing, the big thing I remember back in the 80s is you really got to know who you're talking to and phrase up everything, all your language and your messages to the audience, correct? And so know if they're looking at it as preventive or management treatment protocol. Another talking point is that access, this is Medicaid, to our programs, DSME, by low-income Medicaid patients with diabetes, access is a barrier. Because, hey, Mr. Medicaid, you don't pay enough money. Even though you do cover this, you don't pay enough money or you don't pay for it at all. And so your subscribers in these low-income areas, you know, they're not going to find a program because I had a program, I could not maintain it financially because I'm not getting any money from you. So the program went away in this area. So access gets really limited. Another talking point is implementation of the programs can occur now. This is something new, and I found this out from some of my consulting, is that state departments of public health and areas on aging, area agencies on aging are now 2 new arenas to furnish and implement DSME programs. And there's actually 3 different state departments of public health that have now gotten their programs AADE accredited. And that's how many new public health departments could get an accredited program. I think it's just phenomenal. It's phenomenally fantastic. And that DSME, another talking point, improves select diabetes-related measures. And Medicaid, when we talk about measures, we're really talking about quality measures, or what we call like labs. What gets improved? What is the outcome we want to see with diabetes education? And so Medicaid has what's called adult core set measures that they want to see improved with their diabetes-related type of benefits. And we could look at those measures and we could say we do that in spades. And we are the perfect people to achieve those quality measures. Another talking point, as we all know, and again, I'm not teaching you this is the talking points, the numerous ones to talk to these stakeholders, that diabetes is an epidemic, and it's the surge in the diabetes-related complications and the cost is phenomenal. And you know, one of the triple aims of the Affordable Care Act is to decrease health cost. And health cost is going up with diabetes, especially among African Americans. And that population is a big population within Medicaid programs, correct? That's a huge population. And that, another talking point, that the whole spectrum of outcome measures gets tremendously improved with diabetes ed. A lot of non-diabetes people don't understand that we track and measure numerous quality measures, not just labs, not just clinical, quality of life and behavioral and knowledge and satisfaction. And satisfaction now, the patient experience is a quality measure now that insurance companies are going to ask us to track, and part of our reimbursement is going to be based on that. That medical, another talking point, medical expenditures due to diabetes is 2.3 times higher among patients with diabetes than in patients without diabetes. Again, you all know this, but this is a nice summary of the talking points. And that patients coming from ethnic and racial minorities that have public health insurance, like Medicaid, who live in low-income communities, they have higher rates of type 2, and their rates of hospitalization and medical costs is 55% higher, and that is the Medicaid population. So their costs of care with diabetes in the Medicaid population is incredibly high. Now, the status of Medicaid program expansion, and this is due to the Affordable Care Act and coverage. 31 states, plus the District of Columbia, took Affordable Care Act funding to expand the state Medicaid program. Illinois was one of them, okay? Now, with the good news here, even with the programs who did not take ACA funding and they did not accept the funds to expand, they can still opt to cover diabetes education because the Medicaid is really governed by the state. CMS is over them, but the Medicaid program is a state program. So the state has the authority to add the DSMT benefit onto their list of covered benefits. They have that authority. And then they also have that, they can also add DSMT via the Medicaid waiver program. These are just terms you're going to want to know, that the state has the authority, and they could also add it through the Medicaid waiver program. The other thing you're going to want to know about ACA, the Affordable Care Act, is that if the Medicaid program took these funds to expand, they have to cover certain mandatory benefits because of taking the Affordable Care Act funds. And those mandatory benefits are physician family planning. I could list a lot of them. They're called essential health care benefits. But the programs, these programs who took the funds, the Medicaid programs who took the funds, there's another category called optional benefits. There's preventive benefits and optional benefits. And DSME can fit under preventive services, and it could fit under optional services. So if the Medicaid program took ACA funds to expand, they have to cover certain preventive services like obesity counseling and CVD, self-management education for cardiovascular disease. And they can choose to put diabetes education as a preventive benefit. If they don't, they can choose to put it under the other optional benefits. And because they have those two buckets, those two categories, that's why the reimbursement rules, if they do cover it, change so dramatically from state to state. And states with Medicaid programs, this is the really good news without reading the slide. If they do decide to cover DSME, either under the preventive category or optional benefits, other optional, if they do that, they're mandated now to design a public awareness campaign to let the Medicare, she's shaking her head, you know this, to let the Medicaid enrollees know about these new benefits, whether they're preventive or optional, because they're there, they exist, and they're mandated to roll out these campaigns. Some states include, again, like I said, the preventive benefits under that optional category, and that's why the rules can differ from state to state. Now, some Medicaid programs cover all the U.S. preventative services graded A or B, and like medical nutrition therapy is graded, I think, A or B, which means it's a mandated covered benefit. Some really robust Medicaid programs are doing that. They're covering all of the preventative services. And that's why we see, like California is covering DSMT and MNT. Okay, what we want to do now, I'm going to be up here only for about 6 more minutes because I know I'm standing between you and lunch, okay, is we're going to look at now, and I really applaud the AADE staff for asking me to do this because I think it's really important for you now. What can you do in your state with Medicaid if you come up against a worst case scenario and a somewhat better than worst case scenario with your state Medicaid program? So how many of you want to know some little tricks and tips if you come across this? Because I can present it to you right now. You want to hear this? Okay, great, let's go. Okay, number one, that's worst case scenario. Your state legislature, whatever state you're in, decides that they're going to cut the DSME and MNT coverage. They're just going to cut it out as part of their overall budget cuts because all the Medicaid programs are suffering financially. So there goes DSMT, there goes MNT. So on your right-hand side, what can the diabetes educator do in terms of advocacy to hold off those benefits from being cut? When Medicaid proposes to cut benefits, they have lobby days. They have hearings, public hearings, where good people like us, whether we're subscribers or clinicians, we can go and lobby and try to prevent those cuts. And the Academy of Nutrition and Dietetics has state lobby days every year when there was issues about MNT and nutrition benefits being cut, like WIC and nutrition formulas and things like that. So that's something we can do. Okay, worst case scenario number 2. If your state Medicaid says, okay, we're going to cut our budget, we're not going to cut out the benefits, but we're going to cut the reimbursement to providers. So you're in a state that has DSMT reimbursement by Medicaid, and now your reimbursement rate's going to be cut even less than what it is now. What are you going to do? This is really good news, ladies and gentlemen. If you look over on the right, I'm contracted with the Indiana State Department of Public Health, and this has come full circle. An RNCDE, who's a member of our association, her name is Brenda Jagatic. I was telling her about this worst case scenario number 2, and she says, Mary Ann, please tell the people today. She says, tell them to contact their State Department of Public Health. And there is a diabetes coordinator in every State Department of Public Health. And we can work with the Medicaid program, okay, to help prevent those reimbursement cuts. She says, and we work together, these diabetes coordinators and all these 50 Medicaid or public health departments. She says, I know a public health department in a state where the diabetes coordinator in that public health department, that they work in the same building as the state Medicaid program, and they just have to go across the hall and talk to one another. And because they have that relationship, the public health diabetes person and the state Medicaid person, they have that interpersonal relationship, they're able to circumvent a lot of negative things that are happening with diabetes in the Medicaid program. Okay, worst case scenario number 3, we'll make this really simple, okay? What I've been reading, and this is a somewhat better than worst case scenario. Because the Medicaid programs are basically going insolvent and they're really struggling financially because of state budget cuts, right? A lot of state Medicaid programs are saying, look, we're going to turn it over to a managed care organization. We're not going to run it ourselves anymore. We're going to get an MCO, a managed care organization, to run the Medicaid program. Let them run it because they have experience on how to run it efficiently, cost efficiently. Well, the good news is that Medicaid, the state, will give the MCO so much money per member per month. Per member per month. The state will give that MCO so much money to administer the Medicaid program per patient per month. If they can perform the healthcare services for less than that, the MCO keeps that profit, right? And if they go over that amount they're getting from the state, they eat that risk. And so, when they're on the hook for making money or losing money, they can run the program perhaps a little better. So why is that a better case scenario for you over on the right? Now you can negotiate with the MCO, the managed care organization. And they're used to having people negotiate with them for benefits because that's what they do all the time. And they're efficiency experts. Efficiency experts. And so when you're negotiating, you're going to negotiate for 3 different ways of payment. Traditional fee-for-service, you provide DSMT and you get paid. And that's kind of going away a little bit. The other way is to say, okay, we'll drop the fee-for-service, you can pay us less, but we want the bonus payment, the pay-for-performance, pay-for-quality bonus payment. When we send you our quality measures, when we report the improvement in A1C, the improvement in LDL, the improvement in blood pressure, then pay us a bonus payment on top of that little fee for service. And that's the way the new payment models are going, where the bonus payment, because of reporting quality measures, that's what's making up the bulk of the compensation to us. The third way to do it is to say to the MCO, and this is again a new type of payment model, is look, pay me a bundled rate for my diabetes education. And real simple, real quick, a bundled rate. Okay, this is what you would tell the managed care. I have 10 visits in my program, and I'm just going to ballpark numbers here. This is not to influence you. For the 10 visits, I'm asking for $1,500, okay? But let's break that into 2 payments. $1,000 is the first payment, after the first 5 visits, when I report to you certain quality measures, again, A1C, LDL, blood pressure, I want my first $1,000 when you get the quality measures. Okay, and then 5 sessions later, 5 months later, I want my other $500 when I report the other quality measures that we come to an agreement with on these quality measures. And then you know what, that's my $1,500, pay for performing, pay for reporting. But I want an extra $500 if you give me extra robust quality measures that are more difficult to obtain. And if I could get those extra more robust ones, like maybe GFR or something, I want an extra $500 because I'm making that patient even healthier. So this is going on right now in a lot of insurance companies. Okay, I'm going to hurry up. Let's get done. Okay. We'll skip that one. Okay, the state of Pennsylvania, what this basically is saying, what the state of Pennsylvania looked at is Medicaid savings for A1Cs that progressively went down. So as the A1Cs decreased, their total cost per member with diabetes did what? It decreased. And that's what this is telling you. So last but not least, I promise I'll be off. You have that DAP, D-A-P. I have ADAPT. What's the bottom line for us? ADAPT. A, act in unison. We have to come together and act in unison as groups. Would you all agree? Absolutely. D, decide to never give up. Never, ever, ever give up. As long as we're above ground, we're never going to give up. And A, always keep up with the legislative updates. Come to these programs. Read the legislative updates. We have to know them like the back of our hand. P, plan your strategy carefully with ADA staff, AADE staff, through these kind of meetings, what we're going to do with Medicaid people and insurance companies. And T, train your brain, again, to never say never. So I'm looking at DAP, I'm looking at ADAPT. So thank you very much. I'm sorry I was too long. Thank you.
Thank you very much. I'm a big jazz fan, so we're going to have to improvise a little bit. We were going to talk about licensure, and we're going to have to move that to tomorrow when we have our panel discussion. But there is one issue I wanted to talk about very quickly, and then we can go to lunch, is the current political landscape. So this is how I think a lot of people envision the current political landscape. It's a lot of people with pitchforks and torches, but it's a little more nuanced than that. Not much. In particular, and relative to state legislatures, I thought it would be remiss on our part if we didn't just very quickly go over what's going on in state legislatures politically and what the future looks like, which I don't know what it is, but I think this can give us a quick overview. So the red states are, both chambers are controlled by Republicans. The green states, one chamber is Democratic, the other chamber is Republican. In the blue states, for example, Illinois, both chambers are Democratic. I think what's very interesting, and I think something that the Republicans have been absolutely brilliant about, is you can see back in 1978, the Democrats controlled 31 out of the state legislatures, and that over time has shifted. And now today you have almost the complete opposite, where you have 30 state legislatures controlled by the Republican Party. And this is because it's very smart. They're spending the time, they're spending the money. And really, when you control a state legislature, this is your farm team for congressional races. A lot of people who were state reps, state senators, ended up being federal reps, being federal senators. So for example, the Democratic Legislative Campaign Committee for 2016, their goal is to raise $20 million. Not bad. The Democrats' Advantage 2020 PAC is hoping to chip away at the Republican legislative majorities in states like Florida, Michigan, North Carolina, Ohio, Pennsylvania, and Wisconsin. These are states that Barack Obama won at least once. But here's the other side. This is where it gets interesting. The Republicans are going to spend double what the Democrats are going to spend for state legislative races. They're on goal right now to spend $40 million. I'm not saying that's a good thing. I'm not saying that's a bad thing. What's very interesting is if you pour this sort of money into these down ballot races, even if you have a candidate who hypothetically at the top of the ticket could pull people away from voting for that particular candidate and voting for the other party, a lot of these down ballot races are going to be protected because of the amount of money that the Republicans are spending on these down ballot races compared to the Democratic Party. And I think the thing that's very important to realize is that when you control the state legislature and the census is done in 2020, who writes the redistricting maps? It's the party that's in control of those legislatures. So the Republicans are being very, very smart, and they have a plan to make sure that they're the ones who not only control the state legislatures, but by extension get to control the writing of the congressional maps. So I just wanted to give everybody, that's a very brief overview of a very complicated issue. But I just wanted to make sure everybody was aware of that. Are we out of time? If you don't, that's okay.
Again, we'll touch on this afternoon, but it does help to be involved in this process, and it does help to be involved across the board to make sure that we're not taking our issue to half the government, any half, any majority, everybody. You never know where those partnerships are going to come from. You never know how it catches on with somebody. Elections have consequences, right? You hear that all the time. So do campaigns. What's the opportunity for us? They're out, they have a picnic, they have a little fundraiser, have a town hall, maybe a little more this year than next year. Next year, not their election year, this year, they're getting evaluated. You say, my interest is not diabetes, action, change. Candidates should say, what a coincidence, me too. Even if they're a reluctant convert to putting this as a priority, now's the time to talk to them. This is the year we get. And aside from all the national clutter, and that's being charitable perhaps, so much happens right where you live, so much happens in that State House. We have a chance to engage all those folks this year, especially those who are running.